So at some stage, being an echocardiographer, I want to be in the dark, and so you can see my pictures, because they always look better in the dark. But I'll just have a little chat first. And I'd like to actually thank the organising committee and my good friend Bastian, who we had 2 very pleasant years with in Australia. I appreciate the generosity of the Cardiac Society here, who have allowed the cream of the cream to come to educate us as much as we educated him. So I'd like to say thank you very much for the welcome we've had. I've enjoyed this country. I've been here for 5 days now, and it's a wonderful country, wonderful people. Almost died getting to the top of this historic monument. And I'm just sorry that I didn't keep my portable echo with me, so I could have measured my pulmonary artery pressure as I got to the top. I'm sure that Dr. Collins will have put a cath lab at the top of this Sirigayo in a couple of years' time, so that I can actually have my pulmonary artery pressure measured accurately. But I'd like to refute, as an ex-interventional cardiologist, some of the things he said about right heart catheterisation. It's very hard to get an invasive cardiologist here who actually knows where the right side of the heart is. They spend most of their time dilating coronary arteries. They don't know how to actually manipulate the catheter when it's in the right side of the heart. And so it's not as easy. Dr. Collins can do it. I've worked with him for a long time, but there are several of my colleagues who I would not trust with a Swan-Ganz, and much less with an old Cornand or something similar to that. So a right heart catheter is quite difficult at times, particularly in people with pulmonary hypertension, to actually get a wedge pressure. And so sometimes you have to do a left and a right heart catheter to evaluate these people properly. And it's putting a whole pile of ice-cold saline up a very tenuous pulmonary artery system is sometimes a bit of a risk, I think. Anyway, so I'll go on. So Nick has talked about the need of screening, and I'll talk roughly about the screening, defining the cause, how echo can do that, and defining the severity of the problem, and then monitoring treatment. In our country, everybody almost has to have an echo. I don't know quite why, and we get a whole lot of people referred to us who have pulmonary hypertension. We have to repeat the study because we do have a great deal of overcalling, and we run the risk of labelling people with a terrible disease and exciting their anxiety levels incredibly. Every patient in Australia is informed by Dr. Google, and unfortunately, as soon as they read on the bottom line of their echo test that they've got pulmonary hypertension, they off to their lawyer to get their will renewed. And so it's a dreadful disease, but we do label people unnecessarily. I think we should obviously be targeting high-risk groups, and the patient who has got unexplained dyspnea, and particularly if they've got an abnormal ECG with either right atrial overload or right ventricular hypertrophy, even in its early stages, people with autoimmune disease, and particularly those with CREST syndrome, should be evaluated on a fairly routine basis. Now, Nick has said, and is quite right, that the real primary pulmonary hypertension is very rare, and we have, though, a large clinic of patients with autoimmune disease and rheumatological diseases, and we have been following those patients for a long period of time, and 20% of those, up to 20% of those, will actually develop the real business of severe pulmonary hypertension. HIV, particularly in some parts of Southeast Asia, we have been to Burma on quite a number of occasions. There is quite a risk, and with better treatment of this disease, patients will be surviving for long enough to take into account the quite high incidence of pulmonary hypertension. Congenital heart disease obviously has to be made. Its initial diagnosis is made with echocardiography, and most of these patients now are identified in utero rather than having the situation that we're facing now with some of our patients with Eisenmenger situation. So we have a very high screening program, and the patients are identified and treated early. So we don't have that burden of disease that we did have once upon a time. The most common causes of left heart disease which cause pulmonary hypertension are easily identified by echo. So if you've got left ventricular hypertrophy due to hypertension or due to valvular heart disease, you've got valvular heart disease identified, cardiomyopathy. These are all something that can be easily identified. We have a very high burden of coronary artery disease as well, and this is also usually the patients who have got severe pulmonary hypertension have major wall motion abnormalities, and so they're easily enough picked up. People with lung disease are often very difficult to echo, and the pulmonologists get very excited about trying to persuade us that the degree of pulmonary hypertension is out of order from the point of view of the degree of their pulmonary disease. But we keep them under control if we can. So assessing the pulmonary artery pressure is being partly covered by Professor Nanda, who I was watching as he spoke yesterday, and he gave a very nice talk. But I'll go over the important parts that he talked about, including the measurement of the TR jet, how we can get it wrong and how we can get it better, RA size and in predicting the right atrial pressure, pulmonary artery acceleration time for predicting mean arterial pressure, and pulmonary regurgitation, which also can be used, as well as the pulmonary artery acceleration time to give you a mean pulmonary artery pressure, which is essential in calculating by echo the pulmonary vascular resistance. And I believe that actually we've done ourselves a disservice by calling this disease pulmonary hypertension. It's actually a disease of increased pulmonary vascular resistance, and the disease is not one of pulmonary hypertension. And that as your disease of your with your pulmonary vascular resistance gets worse, as your pulmonary vascular resistance goes up higher, your right ventricle eventually fails, and your pulmonary artery pressure goes down. So the pulmonary artery pressure itself is not a great measure of the disease, and you can't take the pulmonary artery pressure in isolation. So I don't know if you can see that slide okay. That's good. Maybe if we can put the lights down a tiny bit, it might help. But the right ventricular systolic pressure can be measured by the peak tricuspid regurgitation jet velocity. And the simple formula of 4 times the TR velocity plus the right atrial pressure gives you a fairly accurate measure of pulmonary artery pressure, and certainly that holds true when the pulmonary artery pressure is above 45. When you're talking at levels below that, it can be a bit misleading, as Nick has pointed out. So we get variable pictures at times, and we have some good echocardiographers and some ones that are pretty average. And being an echocardiographer, particularly in our world, is pretty hard work because of the obesity problem we're facing, and they always end up with sore shoulders. Anyway, they often apologise for this sort of picture where you can't identify terribly well the peak of the pulmonary artery, the tricuspid regurgitant jet. And certainly yesterday, Professor Nanda pointed out that one of the ways of getting this to look better is to use agitated saline without a bit of blood in it, and you can usually get a much better outline of your TR jet. The other thing you can do, as is in here, you can actually dull the baseline. So by altering the baseline filter settings, you can actually bring out the TR jet much better and concentrate on the high velocities rather than the low velocities, which has been the settings of this TR jet are doing. So there's a lot of problems with the TR jet, and in patients you need to get your jet defined along the parallel with the line of the interrogation, so that if you are offline, you actually may underestimate the severity of your TR jet. Often you need to bring your transducer a little bit forward around anteriorly on the chest wall to actually maximise the capacity and line yourself up with the jet. The colour Doppler sometimes will point out to you, though, that the jet is quite eccentric, and in that situation you really have to be quite inventive in getting the TR jet. If you have your gains up too high, you'll get a bit of a fuzzy outline down at the bottom of the peak of your TR jet, and it's been pointed out that this overgaining produces a beard on the chin, where the chin is what you should be measuring and not the beard. If you've got outflow tract obstruction of your right ventricle, then your TR jet does not measure your PA pressure, it measures your right ventricular pressure. And so you can, if you work hard enough at it, you can subtract the gradient across the pulmonary valve and then derive the true pulmonary artery pressure. But you should be very careful, particularly in people with congenital heart disease, not to overestimate the pulmonary artery pressure if they do have a right ventricular outflow tract obstruction or pulmonary stenosis. Measuring the right atrial pressure is a really difficult area, and probably the best thing is to have a JVP and a ruler. And so the problem is, though, that we have patients that are often very difficult to measure. This is the accepted ways of measuring or estimating the right atrial pressure. If your IVC is not dilated and you're with a sniff, the IVC collapses by more than 50%, you assume that the right atrial pressure is normal and you take 3 as the normal. If either of the IVC diameter or the sniff is abnormal, you see the right atrial pressure as being intermediate and you take 8 millimetres of mercury as the guessing point there. And if both are abnormal, you've got a dilated IVC and the sniff test does not produce much of a result, then you assume that it's at least 15 millimetres of mercury. And so that's an essential part, but a bit of a weakness in this technique. If you've got a patient who's on a ventilator or got a central line in, it's best just to measure the central line pressure and then you can add that on to what you get by your TR jet. Also, a restrictive filling pattern of the right ventricle or a tricuspid E to E prime ratio of greater than 6, or a low hepatic systolic flow in your subcostal view will also determine you have a high right atrial pressure. So another thing we can do with the TR jet is to look at the rate of rise of the pressure in the TR jet, and that can give you a DPDT. It can be a sign of just right ventricular dysfunction, but a person who has a normal jet of tricuspid regurgitation with normal right atrial pressure, a normal right ventricular function, the velocity will rise very rapidly. Here you have this slopey line, and you can measure the rate of rise of the pressure. And most of the commonly used machines now will allow you to bring across a measurement at 1 metre and then at 3 metres and derive the slope of that profile and derive for you a DPDT of the right ventricle. Just looking at it, this is not normal. So looking at this with that slopey curve, this means either right ventricular dysfunction or low DPDT. So pulmonary vascular resistance is important in the failing right ventricle, and we should be measuring that, and that's what we do when we're doing a right heart catheter. And look at the mean pulmonary artery pressure and subtract the left atrial pressure. We ignore the left atrial pressure when doing the echo, assume that it's going to be low, and you divide it by the pulmonary blood flow. And so this is a very useful measurement, and particularly in patients who have got problems with the liver, where you may actually have high pulmonary artery pressure but a very high cardiac output, then this is a way of actually avoiding making the mistake that assuming these people have a high pulmonary vascular resistance just because they have a high pulmonary artery pressure. If the level of your pulmonary vascular resistance is greater than 3 Woods units, then you have significant increase in your pulmonary vascular resistance. Now, I would say that obviously there are mistakes in the cath lab. We have a small industry in the hospital of people running to the cath lab. They keep them very fit, who go and save the interventionalists, and that's happened to all of us, I guess. But it's very rarely that you get a disaster happening from a carefully done echo. The problem with a catheter is that you have a patient who is in a very unphysiological environment. They're sitting there, scared out of their brains, worried that they're going to be killed by these masked men and women. And so and they're in cold, they may be fasted. It makes a difference to the pulmonary artery pressure. We can use the mean pulmonary artery pressure and measure the mean pulmonary artery pressure by planimetering the TR jet, and that can also give you the peak pressure. And most of the machines, when you planimeter, can be set up so that when you planimeter the jet, you get the mean pressure and the peak pressure. The pulmonary valve acceleration time. Here we've got a jet through the pulmonary valve, just below the pulmonary valve, and you measure the time to the peak of that curve, and that can give you a derived formula, through a derived formula, the mean pulmonary artery pressure. It's not as easy as it looks, and so in that you may find it very difficult. And I'm just showing you a picture here of a patient who's had a transesophageal echo, who has severe pulmonary hypertension, and actually had a pulmonary embolus. And you can see here it's obviously quite discrete where you got where you have the peak of that pulmonary valve acceleration time, and so that is a very short period, and so this patient has extreme pulmonary hypertension. In a patient with really established severe pulmonary hypertension, the right ventricle can be quite large, and the orientations and of the valves and the orientations that you can get with a good subcostal view or transgastric view with your transesophageal echo can actually give you very good dynamic information, and particularly that may apply to a patient who's in intensive care and intubated. So using this acceleration time, use this formula. It's a bit tragic, you would think, and the 79 minus 0.45 by the right ventricular acceleration time. And it only is useful when you've got a heart rate between 60 and 100. It seems to fall down a bit outside of that. And basically, it is a pretty accurate estimate of your pulmonary vascular resistance or your mean pulmonary artery pressure, and can be very useful. It was derived by comparing echoes with invasively organised mean pulmonary artery pressure. So obviously you need a high sweep speed if you're going to identify the exact peak, and it's sometimes very difficult. And there are alternative ways of getting a mean PA pressure. We can look at the pulmonary regurgitation jet, and that can be quite useful. This mean pulmonary artery pressure can be gathered by looking at the early pressure difference between the pulmonary artery and the right ventricle, and squaring that, multiplying by 4 and adding the right atrial pressure, and that gives you a very good estimate of usually of the mean pulmonary artery pressure. So how good are these derived pressures? Well, I don't think I ever want to take any one of them by itself. I guess that you take them all, look at them and figure out which one you think you thought of in the first place, so that it may be that these aren't as good as the derived pressures. But the problem is, when you take a patient back to the cath lab, or even if you re-measure the pulmonary artery pressure and the pulmonary vascular resistance within about 10 or 15 minutes of it, you may get quite a different result. So I think that we we have to accept that echo may overcall mild pulmonary hypertension, but certainly it's good. Now I'm going to show some snapshots. This is a pretty classical picture of a patient who's got it's a cross-section of the left ventricle. You can see the right ventricle in front. This is a D-shaped ventricle, and the left ventricle you see is going like the clappers. And this is a patient who was young. She was a doctor at our hospital. She's no longer with us, and she had died of an intracerebral bleed from being on warfarin. But this is the 4-chamber view, a bit off axis. You can see the right ventricular hypertrophy. You can see the very dilated right ventricle and right atrium. The interatrial septum's bowed from the right to the left because of the high pressure. You can see the terribly compressed left atrium, and the left ventricle is tiny. Because of the squashing of the right ventricle onto the left ventricle, the left ventricle is intrinsically slow filling. There's nothing intrinsically wrong with the left ventricle. This is a slow relaxation pattern in a young person just due to the right ventricle making it a slow pattern. So that you have to be careful that you don't actually interpret this as left ventricular disease, because it is left ventricular problem. The left ventricle is suffering, but it's being compressed by the right ventricle. You can see in this person that the plenimetered left ventricular outflow tract ejection produces a cardiac output of 3.4 litres per minute. So that the stroke volume, you can see there, was 41 mils, and the cardiac output there is predicted as 3.4. This is fairly slow, fairly low for a young woman. And you can see here, I'm not quite sure this was taken at the same time, but it is of the same patient. You can see here that the poor filling of the left ventricle has led to failure to sustain systolic ejection. And you can see here, this is an M mode of the aortic valve, and you can see the mid-systolic closure of the valve due to the poor filling of the left ventricle. Going to the 4-chamber view, you can measure the size, the internal chamber size, and you can also measure the area, which is a reproducible number, but I don't think that any of us would delude ourselves that we can actually measure the volume of the right ventricle, particularly in this situation, in any accurate way. And so the ratio of the area of the right ventricle on 4-chamber view comparing systole and diastole is a relatively reproducible number and is a good measure of right ventricular function. You wouldn't think that right ventricle, you couldn't really measure that to see whether it's right hypertrophied or not. This is the same patient. It just goes to show that if you don't get your line, this is really turning around to a 5-chamber view, and that right ventricle looks like it's moving okay. But this is just translational, and it's underestimating the function of the right ventricle. So you have to get yourself right, moved, and well orientated. This is a subcostal view of the same patient. And here you can see how thick that ventricle is. You can see a small pericardial effusion, and you can see it functions very poorly, but there's relative preservation of the apex and of the base of the right ventricle, but the rest of the ventricle moves extremely poorly. So orientation is very important. Here's a patient you can see in the same situation. We've got a pericardial effusion, a very poor prognostic sign for the patient. It's got a few to go. What you see here, this is a patient who has this is a subcostal view. You've got a very hypertrophied right ventricle, but there is a VSD here. Here's the long axis parasternal view, and here is the to and fro shunt through an Eisenmenger VSD. She'd been on treatment for some time. She had a totally right to left shunt. The bosentan actually reversed her shunt so that she actually had left to right for some time. Now she's at the stage of being balanced. So for measuring right ventricular systolic function, there are some recommended things. The tricuspid annular plane displacement, the TAPSE, is very good. The pulse Doppler imaging is very good. You can do that as well. The pulsed wave myocardial performance index, which I'll just show you a couple of pictures of, is very useful. The right ventricular fractional area change is very useful. So the TAPSE, it's best to zoom it because you can actually make a much clearer measurement when you zoom on that, and it's much clearer. The tissue Doppler here, this is reduced, this is 14, the systolic velocity of the annulus, and that is, so this is only 10, so normal is 14 plus or minus 2, and this is reduced. This is the right ventricular myocardial performance index that was originally invented and described back in 1995 and applied to the left ventricle. But basically what you're doing with this is you're comparing the time of ejection to the time of right ventricular filling. And that takes into account the isovolumic contraction time and the isovolumic relaxation time. You are measuring and you're using that as a fraction of your ejection time. So that performance index can be a very useful index of right ventricular function. Measuring the size of the atria and the ventricles is incredibly important. So right ventricular systolic function, we talked about that. What is not recommended at present, I think ejection fractions are just too difficult. The right ventricular DP-DT as a reproducible item is not that good. It reflects both the severity of the pulmonary artery pressure and the right ventricular function, so it is not that good. The strain and strain rate also is a very hard thing to do. It is coming, people are trying to push it along, but it's incredibly difficult to do. And we lack, you get such wide confidence intervals. So I would not try to do that. You're wasting your time. It's a long and tedious thing to do for no benefit. Exercise echo, I just want to have 2 words here from the end because we've been doing this for many years and we're following a cohort of patients. It's very useful to follow patients over a long period of time. And although it's fallen out of favour as a measurement tool, that's partly because our government doesn't want to pay the bills for treating people early when they might actually be well benefited by that. There's not a lot of evidence for early intervention because the drug companies have actually concentrated on the group initially on level 3 and level 4 patients. That really has been, it's really when the horse has bolted, when the fact is that you've already lost the capacity to dilate your pulmonary vascular tree and you have started to decline and you've got irreversible mechanical damage in your lungs. Hopefully one day we will be able to provide a way of screening patients and particularly those who are at high risk and maybe those who are genetically predisposed to actually discover those who will be at risk of developing this terrible disease and actually treat them effectively at a time when we may actually be able to reverse their problems. Thank you.